Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
It's a pleasure speaking to you virtually today about the great changes and progress we've seen with antibody-drug conjugates in the management of breast cancer. Well, as I often say, the last few years have been the time of immune therapy. I think the next years to come are really the era of antibody-drug conjugates in breast cancer. We're all aware of the basic concept of antibody-drug conjugates and the old-fashioned concept and the understanding of how ADCs work. But we've learned that with the next generation of ADCs, there are additional mechanisms. And I think these additional mechanisms are really critical for the substantially increased activity we see these days. One of those effects is that the chemotherapy drug can be released outside the cell again. The other effect can be when the ADC binds to the cell's surface, that the payload, the chemotherapy drug, can be released before the drug actually gets internalized. Those two effects lead to the same benefit. With this next generation of ADCs, we're not just tackling target positive cells, but we can also tackle target negative cells. And this is what's called the bystander effect, which has led to a substantial increase in the activity we see. We've also learned that with this new technology and essentially with the bystander effect in the background, we have no longer have to target the oncogenic driver. With this new technology, we can target essentially any antigen that's expressed on cancer cells, but also possibly, for example, on the tumor microenvironment, vasculature or stroma. And that has really expanded the possibilities for possible targets as we go forward. Cytotoxic payloads we're using are now much more potent than in the past, but there's a lot of research going into finding new classes, new cytotoxic payloads for the future. The final bit that defines the properties of an ADC is the linker. And it's not just a simple glue. It actually is sophisticated biology behind there, because ultimately the linker has to be stable in circulation, but it has to release the payload in a very efficient way at the target site. And there's a whole debate going about whether it's cleavable or non-cleavable and how it's conjugated, because ultimately that will define the properties of the ADCs. If you look at the historic development of ADCs over time, first generation didn't really play a role in breast cancer. They were very heterogeneous drug, relatively low efficacy, relatively narrow therapeutic index. A second generation moved into breast cancer with TDM1 being the main drug that was used there. Where we are now is the third generation ADCs with two licensed drugs in breast cancer, sacituzumab and trastuzumab deruxtecan. The efficacy, even if there's a relatively low expression of the antigen. The key driver of a lot of this is the bystander effect, as I highlighted it before. Where are we heading with the development of ADCs? Obviously, that's not necessarily the topic of today, but just to give you an idea where research is going. For example, on the antibody side, it's looking into fragments and looking into bispecific antibodies, Fc silencing, just again to increase the tailoring and reduce the side effects. There's site-specific conjugation, but also I think a huge work will go into looking at different payloads, possibly even combining two different payloads in the same antibody-drug conjugate. One of the benefits, and just to get back to that point, is there's a plethora of new targets. And this is an incomplete list you see in front of you, going from Nectin to JOP2 to MAC1, LIV1, HER3, just to mention a few of them. And we have a number of drugs that have already come out of phase 3 trials successfully, and we'll focus a little bit more on them. That includes the two TROP2 targeting drugs, sacituzumab govitecan and datopotamab deruxtecan, but also the HER2 targeting ADC, trastuzumab deruxtecan. One of the key themes, and again, I think that's important for everything we discussed today, is what drives resistance to ADCs. For me, a seminal work by the Boston group looked into serial biopsies of the tumor lesions as patients were progressing on sacituzumab, but also looked at different biopsies in an individual patient. And what you could essentially see is even in an individual patient, we have different mechanisms of resistance. In this patient, for example, in 2 lesions, altered binding to TROP2, which leads to target resistance, whereas in lesions in the liver and para-aortic lymph nodes, there was failed binding of the chemotherapy drug, which is ultimately a payload resistance. And so looking at these different mechanisms, we have learned that resistance to ADCs can be subclonal. It's not always every single lesion in a patient that shares the same mechanism of resistance. And we sometimes see something called oligoprogression. So if you have 10, let's say, metastatic lesions, 9 are responding, 1 is progressing. That can happen with ADCs. It may be a better strategy rather than changing the whole systemic therapy, just targeting that one oligoprogression lesion, for example, with stereotactic radiotherapy. We also take our learning around resistance into developing rational sequences or combinations. I will talk a little bit about the combination with immune therapy towards the end of this lecture. The final point before we go into the data in breast cancer is really around toxicity, side effects. So if you say, I know HER2 ADCs and therefore know everything about toxicity, you may not fully understand how those ADCs can work. Each ADC had its unique safety profile. If you, for example, look in front of you at these two ADCs, both targeting TROP2, but 2 different classes, 2 different ADCs have a very distinct, very different side effect profile, with one compound having more myelosuppression, but also gastrointestinal side effects, especially diarrhea, which is probably down to the payload, where the other compound has more dry eye and stomatitis and a small risk of interstitial lung disease. So very different profiles, despite targeting exactly the same target. Now, what I want to share with you today is I go a little bit through HER2-positive disease, then we move on to the developments in ER-positive disease, and we finish with triple-negative breast cancer. You're all aware how we have been treating HER2-positive breast cancer. In primary disease, it is for larger tumors and positive tumors, preoperative chemotherapy with HER2-targeted therapies. In the small tumors, we can also do primary surgery followed by adjuvant chemotherapy with HER2-targeted treatment. And those patients who have neoadjuvant preoperative therapy who have residual disease, we have a standard of care with an antibody-drug conjugate TDM1, as it showed to reduce the risk of recurrence by nearly 50%. When we go to metastatic HER2-positive breast cancer, our current standard is dual HER2 blockade, generally with taxanes. And then again, based on randomized studies that showed that the antibody-drug conjugate second-generation ADC, TDM1, was substantially better than chemotherapy. TDM1 has really been the main standard in the second-line setting. In the third-line setting, it's various combinations of chemotherapy and HER2-targeted treatment. I would like you to focus on the median PFS you see in those slides. So in a first-line setting, with the current standard, we achieve a median PFS of around 18 months. In a second-line setting, with TDM1, you have a median PFS of around 9 months. In the third-line setting, the PFS is around 3 to 6 months. Now, when we look at the new ADCs coming through, the front runner in terms of development so far is trastuzumab deruxtecan. Just putting trastuzumab deruxtecan and TD1 next to each other, they share the same target antibody, trastuzumab. But if you look at the payload, TD1 uses an anti-microtubule, whereas TDX2 uses a topoisomerase 1 inhibitor. There's a difference in the drug to antibody ratio. For TDXD is about 8 molecules glued to an antibody. The cleaver there for TDXD is tumor selective, and it has the bystander effect I explained early on. When we developed TDXD, we saw very early on something very unusual happening in the phase 1 trials. So these are data of 115 patients with 5 or more lines of therapy, and all of them had prior TDM1. All of these patients had a prior antibody-drug conjugate using the same antibody targeting the same target. Well, you can see nearly 60% of patients responded with a duration of response of 20 months. Now, that is substantially more than you would expect in a third of subsequent line setting, where the PFS is usually of 3 to 6 months. The subsequent phase 2 study showed pretty much the same thing, remarkably consistent results, confirmed objective response rate of 60.9%. And so trastuzumab deruxtecan went into a number of phase 3 trials, and there was, after TDM1, so after a previous second generation ADC, either TDXD or treatment of physician's choice, 2-to-1 randomized. As you can see, there was about half of the patients second line, a third of patients third line, about 70% fourth or subsequent line. And the trial was significantly positive, more than doubling of the PFS from 6.9 to 17.8 months, hazard ratio of 0.35. Again, the objective response is here 69%. Parallel, there was a second phase 3 trial, DESTINY-Breast03 run, and that put ADC third generation, trastuzumab deruxtecan, head-to-head with second generation TDM1 in patients with prior trastuzumab taxane therapy in earlier metastatic breast cancer. Again, important to look at the mix of patients in this trial. 10% received it as first line, 39% as second line, about 50% as third and subsequent line. And the trial was equally positive, almost 4 times longer progression-free survival. If you look at the duration of response, 36.6 months, that is a substantial increase in activity. Again, the response rate substantially higher with trastuzumab deruxtecan, nearly 80% response rate with the TDXD compared to 34% response rate with TDM1, and that includes 16% of patients with a complete response. With HER2-positive disease, we always have this question, is if patients achieve a complete response, is there possibly a chance for long-term disease control? And that is obviously our hope. With deeper, more substantial responses, they may even cure in patients with metastatic HER2-positive breast cancer. The benefit in PFS is also leading to a clear signal in overall survival. The median is not reached. As you can see, the hazard ratio of 0.64, very impressive in this setting. And looking at the toxicity profiles, this is where it gets a little bit more complex, because each drug, as I said at the beginning, has its own toxicity profile. If you, for example, look at TD1, you see a little bit more increase in AST compared to TDXD. You also see a little bit more thrombocytopenia compared to TDXD. On the other hand, with TDXD in that trial, we saw a bit more nausea. We saw a little bit more fatigue. And again, one of the side effects we obviously have had to particularly learn how to monitor and manage this was interstitial lung disease or pneumonitis, which can affect up to 10% of patients with TDXD, although with the current guidelines, it's only in a very small percentage of patients clinically significant. Now, the landscape of HER2-positive breast cancer after those data has clearly changed. I've put in this red color the TDXD positioning at the moment, which is very clearly, in my opinion, in a second-line setting. We haven't got the first-line data yet. There's still a question out there in patients who have active brain mets. Is TDXD our treatment of choice as a second-line treatment? Or, based on the substantial activity we have seen with the small molecule tyrosine kinase inhibitor tucatinib, should it rather be capecitabine, trastuzumab tucatinib if patients have brain metastasis? But again, we're getting more and more insight that these third-generation ADCs, including TDXD, have substantial activity on brain mets as well. Now, the data I'm sharing with you now are pooled data from all the HER2-positive trials. As a presentation at last ESMO, well, I think they have been really helpful. As you can see, the pooled data show a response rate of treated and untreated brain metastasis of around 45%, with 15 roughly percent of patients having a complete response. And that is, again, substantially higher than what we would see with standard chemotherapy. That better response of the brain metastasis also leads to an improved progression-free survival, as you can see here with treated and stable brain metastasis, where the median is 12.3 months compared to 8.7 months with standard therapy. But even more impressively, in patients with untreated and active brain metastasis, where the median in this analysis was 18 months compared to 4 months with standard therapy. And I think that compares very well with what we've seen with tucatinib. And it is therefore something we can discuss whether the presence of brain metastasis should change our selection of second-line therapy at this point in time. Where's the journey going? You've already seen how we moved T-DXd from a third-line to a second-line setting. And the open question is obviously, what are the first-line data going to show? We would all expect, looking at an activity of 28 plus months in a second, third-line setting, compared to what we know is usually in the first-line setting of 18 months with trastuzumab, pertuzumab, that trials in the first-line setting will be positive. But we'll have to see how big that effect is and also what the impact on quality of life is. We're also trying to move these ADCs now into early breast cancer. There are studies ongoing trying to replace part of the chemotherapy and HER2-targeted therapy, for example, in the lower risk patients, but also in the slightly higher risk patients as part of the neoadjuvant strategy. And what I'm particularly excited about is the potential of these third-generation ADCs in the post-neoadjuvant setting, where if you extrapolate, which obviously is difficult to do in clinical terms, if you extrapolate what we've learned in metastatic setting, that T-DXd has increased activity over T-DM1, and you look at the position of T-DM1 in the post-neoadjuvant setting, I would be very optimistic. 2 of these trials are ongoing, and we, of course, have to wait for those results. Now, let's move to ER-positive breast cancer, where you're all aware that in metastatic disease, the current standard is to consider combinations with CDK4/6 inhibitors, and as long as patients remain endocrine sensitive, we would continue with second and third line endocrine therapy. But at some point, unfortunately, the tumor becomes hormone refractory, and we have, in the past, we had to switch to chemotherapy strategies, serial chemotherapies, first, second, third, fourth line. But we've now learned that these ADCs can also play an important role. We have phase 3 data with 3 ADCs, DESTINY-Breast04 with trastuzumab deruxtecan, so HER2 targeting ADC in patients with low expression, then TROPiCS-02 with sacituzumab govitecan and TROPION-01 with Dato-DXd. If you look at the data with trastuzumab deruxtecan, and this is, you will say, why are we using a HER2 targeting ADC and ER-positive HER2-negative disease? Now, we call it HER2-negative disease, but actually, this is in patients with low HER2 expression. Patients who have HER2 IHC 3+ or 2+ with amplification have essentially HER2 as an oncogenic driver, and those patients in the past did benefit from HER2-targeted therapy with trastuzumab. But with this new generation of antibody-drug conjugate, it is actually enough if you only have a little bit of HER2 expression on the tumor cell. You don't have to have high overexpression. Even IHC 1+ or 2+ is enough and has shown us in the past in small studies that it drives a benefit for HER2 targeted therapy with trastuzumab deruxtecan. And this was the basis for the DESTINY-Breast04 trial in patients with low HER2 expression. Low is defined as IHC 1+ or 2+, as long as there's no amplification of the gene. There's a trial in patients with metastatic breast cancer. Most of those patients were hormone receptor positive. A small subgroup was triple negative. In fact, 60 patients out of a total of 540 patients. And patients obviously had to be hormone refractory. Were randomized 2-to-1 to trastuzumab deruxtecan or standard of care treatments of physician choice. Now, when you have treatment of physician choice trials, it's always important that you look at the control arm. Is the control arm really active? And in this trial, the control arm, in my opinion, was optimal. More than half of the patients had eribulin, which is the most effective chemotherapy in that setting. Primary endpoint progression-free survival, secondary endpoint overall survival. The population, most patients, 58 had HER2 1+, 42% HER2 2+. Over 60% received this treatment as second line, the rest as third line therapy. And if you look at the progression-free survival, again, a significant and meaningful improvement from 4.2 to 9.6 months. The same thing as I highlighted earlier in HER2-positive disease, we see across ER-positive and triple-negative disease as well, significantly higher response rates of around 50%. And again, chemotherapy was at around 16% in that setting. That was the same whether it was ER-positive or triple-negative. And that has been associated with an improvement in overall survival from 17 to 23 months. And that is relatively consistent across all subgroups. Importantly, not affected by prior CDK4/6 inhibitors, not affected by the lines of therapy, not affected by whether patients have an IHC 1+ or 2+ tumors. These second and third compounds we have now developed in ER-positive breast cancer are TROP2 targeting antibody-drug conjugates. Now, for those of you who haven't heard of TROP2 is probably not the most exciting protein from a breast cancer biology point of view. There's now data coming out that it plays possibly a role in cell proliferation and transformation. But in all honesty, it's not your major driver of breast cancer biology. But it's a fantastic target for an antibody-drug conjugate. It's overexpressed in breast cancer, but also in other cancers, lung, GU cancers, and it isn't really expressed in normal tissue. So whilst it's biologically not that relevant, it's a great target. It's a great anchor for our targeted chemotherapy. We have two ADCs that are through phase 3 development, sacituzumab govitecan, which has a humanized antibody, an SN38 payload. So SN38 is a derivative of irinotecan, which explains some of the side effects. And again, as all these third-generation ADCs, it has a linker that leads to a bystander effect. The second drug has just come through phase 3 trials, not yet approved, datopotamab or Dato-DXd, uses the same deruxtecan, as you know, from trastuzumab deruxtecan, and a tetrapeptide linker, again leading to a substantial bystander effect. If you first look at the data with sacituzumab govitecan, CHOPWIX-02 trial, again, we're talking ER-positive, HER2-negative breast cancer, this time without a TNBC cohort in there, slightly different group of patients. And I think that's really important to highlight, well, because we shouldn't, but we all do, compare trial A with trial B and trial C. And so it's important to realize the majority of patients were a bit more pre-treated in this trial. They obviously were hormone refractory, had at least 2 to 4 lines of prior chemotherapy, and they were randomized to sacituzumab or treatment of physician's choice, similar control arm, again, with the majority of patients receiving eribulin. And I think that's really important when we look at the results of the trial. We see a meaningful improvement in progression-free survival. Hazard ratio is 0.65, which is probably the better way of looking at it, because obviously with the more pre-treated cohorts, the medians are a little bit lower, 4 months with treatment of physician's choice, 5.5 months with sacituzumab. And we see that benefits consistent across all subgroups, depending on prior lines of therapy, etc. It's a stable benefit, sacituzumab over chemotherapy. It also leads to a benefit in overall survival, hazard ratio 0.79 from 11 to 14 months, and we have an increase in response rates. Well, the question often comes up is what about the activity in HER2 low or HER2 zero? We wouldn't expect HER2 to be a differentiator in the activity for sacituzumab govitecan, because low HER2 expression is not changing the tumor biology. And as you can see here very clearly, the PFS benefit was very similar whether patients were HER2 low or HER2 zero with sacituzumab compared to standard treatment. Looking at the safety profile, again, it's a distinct profile as any ADC has. We see here a little bit more neutropenia compared to treatment of physician's choice, and more GI, diarrhea, toxicity, which is down to the irinotecan payload. Now, one of the experiences from us in clinic is when we developed those drugs in the clinical trials, we probably saw a little bit more toxicity. But now that we have been working with these drugs, and that applies to T-DXd as well as to sacituzumab, we found ways to manage the side effect much better. So, for example, with prophylactic loperamide application, the diarrhea rate in our clinical practice is pretty low. With primary or secondary G-CSF supplementation, we see a much better, much lower neutropenia rate. And ultimately, the tolerability of these drugs is going up as we and our teams develop more experience. The discontinuation rate with sacituzumab, as you can see on the right side of the slide, was pretty similar with sacituzumab compared to treatment of physician's choice. The third drug I wanted to introduce to you today is Dato-DXd from the TROPION-Breast01 trial. Again, similar design, similar to the T-DXd trial in as much as patients were second or third line, so not quite as much pre-treated as patients in the sacituzumab trial, just ER-positive patients, one-to-one randomized, day 2 versus treatment of physician's choice. As I said before, effective control arm, majority of patients on eribulin, dual primary endpoints, PFS and OS, relatively short median follow-up at this point in time. That's why we haven't got mature OS data. And 62% had second-line therapy, only 38% at third-line treatment. We see a meaningful improvement in progression-free survival. The hazard ratio is practically identical to what we saw with sacituzumab with 0.63 here, which is an improvement from 4.9 to 6.9 months. And again, that benefit was very stable across subgroups, including the prior lines of chemotherapy and prior use of CDK4/6 inhibitors. We see, as with all ADCs of third generation, an important improvement and increase in objective response rate, which I think is important to highlight because that's associated with a clinical benefit and symptomatic improvement for patients. The safety profile is distinct, as with any ADCs. We see more ocular events in form of dry eyes, which we have seen with other ADCs as well. We see gastrointestinal side effects, but less diarrhea, but more stomatitis here. And again, there are strategies that have been developed to mitigate, for example, the ocular or stomatitis side effects. And with experience, again, our experience is very positive that we managed to increase the tolerability compared to those trials. Now, I've put together the 3 different trials, and I on purpose did not want to put in the efficacy data of the ADCs because we shouldn't do cross comparisons. But I wanted to highlight here the differences in the patient population. If you look at the TDXD trial, 58% second line, sacituzumab only 2% second line, Data-DXd 62% second line. If you look at fourth line, 1% of no patients with the DXD programs, but 57% with sacituzumab. So if you look at the control arm response rates, are obviously lower in patients who received sacituzumab, and the PFS is lower. And I think we need to take that into consideration when we look at the different data as what we shouldn't do cross-compare trial data. So where are we with ER-positive breast cancer? We have new standards of care in patients HER2 low or HER2 zero, where I would see now those ADCs as a standard of care in a second, third line setting after first-line chemotherapy. But where's the development going here? We obviously trying to work out how much of the target expression do we really need, in particular for HER2. We need to work out how we sequence those ADCs, because we will soon have 3 ADCs available for the same indication, but we don't know how ADC 1 works after ADC 2, and rational ideas how to sequence those drugs are important. And we need to look at combinations. I'm particularly interested in the combination with immune therapy. Let me finish off with triple-negative breast cancer, obviously a topic that's always very close to my heart. If we go back 3 years, the management of triple-negative breast cancer had already improved substantially compared to 5 or 6 years ago. We had introduced the combination of chemotherapy and immune therapy as a new standard of care in stage 2 disease. And again, in patients who respond really well, have a complete response, we scale down. In patients who have residual disease, we try to scale up and give post-operative therapy, whether it's capecitabine or olaparib in germline mutant patients, or whether it's the continuation of immune therapy. In the metastatic setting, and this is where the ADCs are at the moment, we had new standards for first line. The standards remain chemotherapy and immune therapy in patients with PD-L1 positive tumors, and then patients with PD-L1 negative tumors, usually taxanes or platinum. Second line, we chose those chemotherapies that were left, and sometimes in the third line setting, we were already running out of feasible options, and patients sometimes received best supportive care. Now, this is where the ADCs came in, and sacituzumab govitecan was the first ADC really to enter phase 3 trial in triple-negative breast cancer. Trialed in the ASCENT trial, this is in patients metastatic triple-negative breast cancer who have had progression after 2 prior lines of therapy. Patients on average were heavily pretreated with on average a median of 4 treatments. The trial randomized sacituzumab versus treatment of physician's choice, same options, same characteristics, that eribulin was the most commonly used drug there, primary endpoint progression-free survival. And not surprisingly, having looked at the phase 1 data, there's a highly meaningful benefit of sacituzumab govitecan over treatment of physician's choice. trebling of the progression-free survival from 1.7 to 5.6 months, hazard ratio 0.41. Even in patients who had brain metastasis, we see a very, very similar benefit. The benefit is consistent across all subgroups, and there are a few subgroups I always highlight. One is the number of prior therapies. So patients who had 2 to 3 or more than 3 prior therapies seem to derive a similar benefit compared to chemotherapy. So if for whatever reason your patient hasn't received it earlier, it's still worthwhile giving a patient later on sacituzumab because it remains a highly active drug. And important, patients, whether they started their journey as triple negative or turned triple negative over time, they seem to derive a comparable benefit with sacituzumab over treatment of physician's choice. Now, it's not surprising that this substantial benefit in PFS leads to an overall survival benefit, doubling of OS from 6 to 12 months, hazard ratio 0.48. And again, the final point to make here is around objective response. Now, what was a little bit shocking to all of us was to see how low the response rate with standard chemotherapy are, of 5% in a randomized trial. And that's 7 times higher with this ADC with a response rate of 35%. That's really important from a patient perspective. If you have a patient in front of you who's symptomatic because of their disease, for example, short of breath because of lung involvement, you're not going to improve those symptoms unless you see an objective response. So the objective response is linked with a clear improvement in quality of life whilst patients are on this therapy. What about TROP2 expression? Do we need to measure it or not? Now, with the understanding we have now around HER2, we know that these third-generation ADCs don't really need very high expression of the target. But we looked at this in the ASCENT trial. As you can see in the pie chart, about 80% of patients have medium or high expression of TROP2, only 20% are low. And you can see even in patients with low expression, the response rate are substantially higher compared to chemotherapy. And also, if you look at overall survival, if you look at the group with the lowest TROP2 expression, the overall survival is still better than with treatment of physician's choice, suggesting that we don't need to establish the target expression when we treat with these third-generation ADCs. Dato-DXd, we mentioned it in ER-positive breast cancer, and triple negative, we haven't got phase 3 data. We have small phase 2 data, which shows substantial activity. What I've highlighted here in color coding, I think is really important. So you see in this red color, patients who had prior sacituzumab therapy. So these are patients who received a different ADC targeting the same TROP2 target and then received subsequently Dato-DXd, and some of those patients still responded. You see in yellow patients who had the same payload before with a different antibody-drug conjugate. And again, one of those patients still responded. So it highlights what I said at the beginning, that the resistance can be driven by either target or payload, and we will need to work out in the future how best to select patients for treatments going forward. We've already looked at the data with TDXD, the DESTINY-Breast04 data, but here split up between ER-positive on the left side and triple negative on the right side. You see basically the same hazard ratio in TNBC as you see in ER-positive, hazard ratio of 0.46, and the same OS signal, hazard ratio 0.48. The caveat is this is based on around 60 patients, but the activity seems to be comparable to what we saw in ER-positive breast cancer. So where does it leave us in triple-negative breast cancer? We have a clear change in the standard of care. We have sacituzumab as early as second line in patients with metastatic triple-negative breast cancer, and then also trastuzumab deruxtecan in subsequent lines, especially in patients with HER2-low disease. Now, one of the things I mentioned earlier is where do we go from here? And I'm really excited about the prospects of combinations with ADCs, and in particular, combination with immune therapy. You may have seen the Begonia trial. Begonia is a platform trial, first-line metastatic TNBC, that we set up to look into new combinations of immune therapy with other drugs. And that was agnostic to PD-L1 status. So we have PD-L1 positive, PD-L1 negative patients. As just to remind you, immune therapy had really only shown a benefit in PD-L1 positive patients. We have combinations of ADCs. We have trastuzumab deruxtecan in there, but also Dato-DXd, TROP2 target ADC, together with durvalumab, an immune checkpoint inhibitor. And if you look at the data as we presented them at ESMO 2023, Objective response rate 79%, but you need to read the small print. 87% of patients were PD-1 negative. So here you would expect a response rate of around 40-45%. It's 79%. If you look at the median PFS, 13.8 months, and again, considering the benchmark of around 5 months, the median duration of response of 50 months, there's something substantial happening. And it may just be that these ADCs are so good in a first-line setting, but I believe there's a true potential for synergistic activity between ADCs and immune therapy. ADCs are a massive disruptor of the tumor microenvironment. And you can imagine that there's a high influx of immune cells. And so it is even conceivable we need to test whether the paradigm that only PD-1 positive patients respond to immune therapy in metastatic triple-negative breast cancer is still correct when we combine immune therapy with ADCs. So where are we heading in triple-negative breast cancer with ADCs? There's a number of studies ongoing in the early disease setting. I think there's exciting potential to replace at least part of the neoadjuvant therapy with ADCs in combination with immune therapy. Our current standard, capecitabine, is not a very effective drug. You have seen that sacituzumab had a 7 times higher response rate in the metastatic setting. And so there's a number of ADCs going into this post-neoadjuvant space alone or in combination with immune therapy. And I would be very disappointed and also slightly surprised if we wouldn't see a benefit here from ADC therapy. In the metastatic setting, this is the current standard, but what we're exploring is what do we do with immune therapy in patients who already had immune therapy in the early disease setting? But more importantly, where are we moving with those ADCs? Are we combining them with immune therapy just in PD-1 positive patients or possibly in PD-1 negative patients? And how do we sequence them? And that's the job for us to do in the next 2 or 3 years. But I think with the development of ADCs, the world of breast cancer management has become much brighter. Of course, these drugs aren't perfect, so there's still some off-target toxicity. The new ADCs, the third generation, as I call them, can be effective in really, even if there's a very low or possibly undetectable targets. Now we have ADCs, part of guidelines for all subgroups, ER positive, HER2 positive, triple negative. The use of ADCs even resulted in the definition of a new biomarker-driven subgroup, HER2 low. And of course, we are now exploring the ADCs in earlier disease setting. For the future development, there's a lot of things we can still consider. We are still trying to work out the dynamics over time of the target expression. There's a need for different payloads that are ideally non-cross resistant. And I'm personally really looking forward to seeing more data of combinations, especially with immune therapy. Thank you very much.